Hi, my name is Heidi Aston. Today I'm going to do a presentation on the team approach to CPR. A little bit about myself. I worked here in McDowell County as a 911 telecommunicator. Been with them since 2009. I'm also a paramedic for McDowell County. I've been with them since 2013. So today we're going to do team approach to CPR. Why does this matter to me? 88% of cardiac arrests occur at home. If called to administer CPR in an emergency, the life you save is likely to be someone at home, a child, a spouse, a parent, or a friend. CPR can double or triple a victim's chance of survival, but only 32% of cardiac arrest victims get CPR from a bystander. It's very important that bystanders initiate CPR before a first responder or ALS can arrive on scene. I'll tell you a little story. When I was working in the comm center at night, received a call from a lady who could barely speak, and she was getting out one breath at a time, or one word at a time. Knew this was going to be a bad call, got the supervisor and the ambulance and first responders started to her. I talked to her and tried to calm her down, told her not to try to talk to me, that I would just stay on the line with her. Well, while the ambulance and first responders are en route, she drops the phone, and I can't hear her breathing anymore. Once they arrive on scene, she's in cardiac arrest. They said that she was blue from her waist up. This was a safe for us. And this patient was resuscitated. We did get Ross, and we did a code freeze on this patient and transferred her straight to mission. The critical concept of high-quality CPR. The healthcare provider should briefly check for unresponsiveness, breathing or no breathing. Simple as that. Then they need to activate the emergency response system and get an AED. Activating the emergency response system is as simple as calling 911. We need to initiate CPR immediately. Push hard and fast in the center of the chest at a rate of at least 100 compressions per minute. Compressions need to be at least 2 inches deep on an adult patient. Minimize interruptions and compressions less than 10 seconds. We need to allow the chest to come to a full recoil when you're doing chest compressions. Otherwise, you're not delivering an adequate compression. Avoid hyperventilation when assisted with ventilation. You want to keep it at 8 to 10 breaths per minute. We arrive on scene and you're doing ventilations with a BVM, and you've got your partner up here doing CPR at a rate of 100 compressions per minute. And you make it exciting, and you're just squeezing the bag and squeezing the bag. You're not even counting how many breaths you're giving that patient. You're hyperventilating that patient. And we need to keep the breaths 8 to 10 breaths per minute. Increased focus on team approach CPR. McDowell County has adopted the team approach CPR in the last 3 to 4 years. We've had excellent results with team approach CPR as well. The chain of survival. Immediate recognition of cardiac arrest and activation of the emergency response system. Again, it's 911. Telecommunicators are trained to give CPR instructions over the phone by phone. Early cardiopulmonary resuscitation, CPR, with an emphasis on chest compressions. The American Heart Association is moving more towards hands-only CPR. It is effective, and it's been proven to work. Rapid defibrillation. A lot of your churches and your businesses and your schools have AEDs in them. We need to get people more trained on these AEDs and get them ready for a cardiac arrest event if it is to occur at the facility. Effective advanced life support, your ALS, that's your EMS. Integrated post-cardiac arrest care, that's what I was talking about with my story earlier. We did achieve Ross on that patient. She was put into code 3 and transported emergency traffic to mission. Let's go over single respirator CPR for the adult. We're going to take the CAB approach. This has changed from the ABC approach that we were all taught for years. It's now the CAB approach. Compressions, airway, and breathing. We're going to assess for a pulse responsiveness and breathing. This should take less than 10 seconds. If no response, we need to immediately get on that chest and start chest compressions. 30 compressions with 2 breaths. Keep interruptions less than 10 seconds. When you administer 30 compressions and you got to give your patient 2 breaths, you're by yourself, you need to be very swift about it. Continue the cycle ratio up 32 for 2 minutes or 5 cycles, and then you're going to reassess the carotid pulse. Remember that hands-only CPR is an option, and sometimes if you're the only person on scene, it is the best option. Let's move on into 2 rescuer CPR for the adults. Now you've got 2 people on scene. That's great. You're going to need all the help you can get. Let's assess for a pulse responsiveness and breathing, less than 10 seconds. If no response, get on the chest and start compression. Again, 30 compressions and administer 2 breaths. Less than 10-second interruption. There shouldn't be no interruption during this. You're going to immediately do your 10 compressions, and then your partner, who's up at the head of the patient, is going to deliver 2 breaths back on compression to go. Continue this cycle at a ratio of 32 for 2 minutes or 5 cycles. Reassess for a pulse. After 5 cycles or 2 minutes, the rescuer is going to switch roles. When it says after 5 cycles or 2 minutes, if you have an AED in place, your 2 minutes comes into play. Every 2 minutes, it's going to reanalyze the rhythm. That means you have to have hands off the chest. It's going to take less than 10 seconds while it's reanalyzing. You switch roles. You're coming off compressions, going to airway, airway is coming off airway, and going to compressions. Talk a little bit about the basic airway maneuvers. A head tilt chin lift is performed by placing a hand on the frontal occipital bone and the fingers of the other hand on the bony prominence of the chin. We need to apply pressure to the forehead and push. As you see in this picture here, this is a patient just laying supine who has his airway is not open, it's completely blocked off just below the epiglottis or just above the epiglottis. Perform a head tilt chin lift. Now we have an open airway, we can provide ventilation. I'll show you a little demonstration on open airway. So place one hand on the forehead of the patient, your other hand you're going to take your fingers and place under the bony structure of the chin. You lift up with your fingers and push down with your hand. Now you have an open airway. Simple as that. Let's talk about a BVM, a bag valve mask for adults. We need to properly position the mask to achieve an effective seal while holding the airway open by using the C to E clamp technique. By using the thumb and the index finger of one hand to make a C, pressing the edges of the mask to the face. Using the remaining fingers to lift the angles of the jaw. 3 fingers form an E and open the airway. Let me demonstrate that for you. So we have just a simple bag mouth pass. I'm going to remove the face seal and just show you the C to E technique. So with your thumb and your forefinger, you're going to create a C. The mask should fit the face. The narrow end of the mask is going to go over the bridge of the nose, and the wide area of the mask is going to go around the chin on the front of the face. Using your C to E technique, you create a C with your thumb and forefinger, and then wrap the remaining 3 fingers around the bottom of the chin. You're going to pull the patient's chin up into the mask and press down on the mask to create an effective seal to ventilate this patient. Always keeping the airway open. Now, when we squeeze the bag to give a breath, we need to do it over 1 second. While watching for the chest to rise, if the chest doesn't rise, we need to reposition the airway. The delivery of breath is the same whether you use supplementary oxygen or not. So this reservoir here is for your supplementary oxygen. It's going to fill when you have high flow O2 applied. If you don't, just simply take this off. We're going to squeeze this bag over 1 second to effectively administer a breath. You want to minimize interruptions and compressions. Again, less than 10-second interruptions. Okay, another more advanced airway is a BIAD. It stands for Blind Insertion Airway Device. What I have pictured here is King LTD. LTD. Remember that compressions do not need to be interrupted to insert a biad in the patient. Compression ratio is no longer 30 to 2. We're going to do continuous compressions at a rate of at least 100 per minute. Ventilations need to be given at a rate of 8 to 10 breaths per minute. That is a breath every 6 to 8 seconds. Again, avoid hyperventilation of your patient. It's important not to hyperventilate the patient, and remember that breaths do not need to be synchronized with the compression. EMT basics can insert a biad. That is great that they arrive on scene first, and if it's way out in the county where you've got a 10 to 15 minute response with your ALF unit, they go ahead and drop the king. We're not going to take that king out when we arrive on scene if they have an effective airway going. Little indication and contraindication for using a biad. Your patient has to be unconscious with no gag reflex in the back. The patient must be over 4 feet tall. Do not use on patients who have known esophageal disease. Do not use in patients who have ingested caustic substances. So I'm going to show you a little video on the King LTD. It'll take about 3 to 4 minutes. Bear with me just 1 second.
The King LTD is a single-use alternative airway device. The King consists of a curved tube with ventilation holes located between 2 inflatable cups. Both cups are inflated using a single pilot balloon. The proximal end of the tube has a universal 15 millimeter BBM coupling. As you can see, there are 3 sizes to the tube. The number 3, or yellow, is for patients 4 to 5 feet tall. Red, 5 to 6 feet tall, and finally the purple for patients greater than 6 feet. The amount that you would inflate each cup also varies from tube to tube. 45 to 60 milliliters on the size 3, or yellow, 60 to 80 milliliters on red, size 4, and finally 70 to 90 milliliters on size 5, or the purple King Airway. Per the Oakland County Protocol, the King Airway should be used after 2 unsuccessful endotracheal intubations. The King Airway is indicated for patients greater than 4 feet tall. It's contraindicated in patients with a known gag reflex, a known history of esophageal disease, and recent ingestion of any type of caustic substance. It's important to note that the King Airway does not protect the airway as well from regurgitation and aspiration of stomach contents. So your patient's in respiratory distress, intubation attempts have been unsuccessful. It's time for the King Airway. Packaged with the King Airway is the syringe and lubricant. Apply a chinlet and introduce the device into the corner of the mouth. Without exerting excessive force, advance the tube until the colored connector is aligned with the teeth or gum. Make sure that you inflate the cups appropriately for the color you have selected. Attach your BBM and start gently bagging the patient. And slowly withdraw the tube until ventilation is easy and free-flowing. Secure your tube and monitor tube placement while en route to the hospital. The end tidal CO2 detector should also be placed in line between the airway and the bag valve neck. All of these steps are outlined on the quick reference insert included in the packaging of all the King Airway devices.
All right. So, any questions from there? We're going to move on and talk about the AED and cardiac arrest patient. AEDs are the EDS 1, 2, 3. So, I have a training AED that I'm going to use for this demonstration. First, I'm going to apply the pads to the patient's chest. First pad, as you see, on the AED, or on the pads, it shows you the exact placement that you need to use. So I'm going to go ahead with that. Alright, and just to show you, here's the placement of the pad on the patient. Like I said, on each pad it shows you exactly how to place. Very simple. I'm going to turn the AED on.
Training mode. Call for help. Analyzing heart rhythm. Do not touch the patient.
Okay, so we're going to activate the emergency response system,
Shock
which is 911.
advised. Charging.
It's
Stand
analyzed the
clear.
patient. It's advising we need to shock this patient. So everybody clear, all
Press
clear,
flashing shock button.
and we're going to
Shock
shock.
1 delivered. It is safe to touch the patient.
Okay, so as soon
Begin
as it's
CPR now.
safe to touch the patient, we're going to get back on the chest and perform compressions. I'm going to turn that off so it doesn't interrupt us. So, we will, anybody that wants to come and get training on the AD, we will have it all throughout class. It will be available. Okay, team approach to CPR. There's a nice little picture of squirrel performing CPR on his little buddy. Alright, rescuer positions in a resident, BLS first on scene. BLS is our basic life support, that's going to be our first responders. Okay, so you see we have the patient lying supine to the patient's right. You have the first responder start all compressions, only CPR. You have the second responder who will come in and take over compressions, and then the first responder will move to the airway. After placing the AED, rescuer 1 proceeds to the airway and secures BIAD if he has one. The AED is down here with rescuer 2 now. We've already applied it. We're doing compressions, your 30-to-2 ratio. This is for a BLS first on scene. Now we're moving to ALS on scene. Your BLS should already be on scene. Your first responders are typically the first ones there. So, right here we have your first responders to the right of the patient again. They're going to be interchanging CPR every 2 minutes or 5 cycles of CPR. EMS comes into the patient, they're going to the left and to the airway. So, you have your attendant who goes straight to the airway of the patient. If a BIAD's not already in place, this is where the patient's going to be inserted, or intubated. Your driver should carry in your monitor and drug box. They are in charge of the IV and medication delivery. Any questions on BLS and ALS responders? Okay. Moving along, now we're in the back of the ambulance. We've got this patient loaded, we're ready to go. CPR is still in progress. Same systematic approach. You've got your ALS, EMS, IV tech, and medication delivery to the left of the patient. You're going to place the monitor On the bench, your airway medic's going to be in the captain's chair at the patient's head. Jump bag is going to be on the floor next to the airway medic. Then your CPR seats, where you're going to have your CPR certified rescuers, which will probably be your first responders. You're going to have one rescuer standing up giving compressions while the other rescuer is sitting down in the CPR seat. Now for us, the way that works is the CPR attendant who's sitting has to hold on to the CPR attendant who's delivering compressions because we have a mountain to go up. So it's this little extra security that we provide. When they switch out, they're going to take less than 10 seconds to switch. Okay, so any questions on in the back of the unit? Just a few take-home points for Team CPR. The first arriving BLS responder will carry in the AED if available. If not, they're going to go straight in and get on compression. Second responder will carry in the jump bag, oxygen, and assume compressions from the first rescuer who arrived on scene. The first rescuer moves to the AED, places the AED on the patient, then moves to the airway. Do not interrupt compressions. When the third rescuer arrives on scene, he will establish a team leader and rotate compressions. Team leader roles. This is part of the team CPR approach. We now have team leaders. They maintain responsibility over CPR and rotating compressions through the entire event or until relief of duty. They act sort of as a liaison. They're telling their responders that they need to switch out. Hey, you've done 2 minutes. You've done your 5 cycles. Go ahead and switch out. We don't want you to get exhausted. It is an exhaustive process sometimes. You want to manage the scene and the bystanders. Sometimes you're going to have a lot of family, a lot of friends in the room. They want to know what's going on. We need to let them know what's going on. Ensure high quality compressions are being performed. If we see a decline in compressions, we need to switch out that responder. Ensure that frequent compression change every 2 minutes or 5 cycles of CPR. They are responsible for briefing families prior to ALS arrival. When ALS arrives on scene, there's going to be a lot of interventions taking place, and we need to go ahead and let the family know what is going to happen. How do I ensure that I'm doing high quality CPR? Ensure that your compressions are at least 2 inches deep. You want a rate of at least 100 compressions per minute. And if the monitor is in place, you need to look for a entitled CO2 value. If this number begins to decline, it's time to switch out your compressors. All right, so now we're going to start talking about the pediatrics. We're all intimidated by pediatrics. There is smaller versions of us. So what's different about the pediatrics? They're disproportionately larger tons than those of an adult that can block an airway. They're disproportionately larger heads than adults. They have a smaller upper airway and softer airway structure. So when we go into intubate these pediatric patients, we need to use caution in their mouths when we're moving stuff around because their airways are softer and they could be harmed easier. So if you see, I've got an infant trachea and an adult trachea. You see the cone shape in the infant trachea, how it shapes down to a cone, and then how the adult trachea is more in a straight position. Also, the heads, here's a child's head and an adult's head. And what it's wanting you to see is the proportion of the tongue to the inside of the mouth and the airway divided. Okay, so infant and child CPR concept. Continued emphasis on quality CPR with minimal interruptions and compressions. Again, this is an adult. When we're doing compressions, we're going to change it up. We're not going 2 inches. We're going to go a third of the depth of the chest. In some cases, that could be as much as 2 inches, but you need to be careful not to overcompress on a pediatric patient. You want to go at least 1.5 to 2 inches deep. You may use only a single hand on a child. That is effective if you don't use 2. You want to keep your compressions at a rate of at least 100 per minute. Some compressions can be performed with 2 fingers or 1 hand, depending on the size of the patient. In a pediatric patient, we're going to assess the pulses in the brachial artery. Their necks are small, their heads are big. It's hard to get up and assess a carotid pulse in a pediatric patient. So we go for the brachial. Single respiratory CPR for a child or infant. Again, assess pulse responsiveness and breathing. Keep this less than 10 seconds. If no response, immediately begin compression. After 30 compressions, we're going to administer 2 breaths. Less than 10 seconds, interruption again. Continue the cycle at a ratio of 30 to 2 for 2 minutes or 5 cycles of CPR. It's the same as an adult, single rescuer CPR. Okay. So 2 rescuer child infant CPR. Again, assess for pulse responsiveness and breathing, less than 10 seconds. If no response, immediately begin compression. Now we're changing it up a little bit. We're going to a ratio of 15 to 2. We have 2 rescuers on scene. Your compression ratio and compression to breath ratio goes to 15 to 2. After 15 compressions, we're going to administer 2 breaths. Less than 10-second interruption again. Continue the cycle to ratio of 15 to 2 for 2 minutes or 5 cycles of CPR. Okay, a BDM for an infant or a child. Again, we're going to properly position the mask to achieve an effective seal while holding the airway open using an E-to-C clamp technique. Using the thumb and the index finger of one hand to make a C, pressing the edges of the mask to the face, use the remaining fingers to tilt the angles of the jaw. 3 fingers form an E and open the airway. This is just like an adult. Remember to leave the airway in a neutral or sniffing position. Now this is different. Why are we leaving the airway in a neutral or sniffing position? As I showed you how their trachea, if it's a cone shape at the top of their trachea, their tongues are larger in their mouth in proportion to the space that they have. Their heads are also larger and their small necks. So if we leave them in a neutral or sniffing position, that actually opens their airway better than doing a head tilt chin lift. We'll cut their airway off and we won't be able to deliver an adequate breath. Again, we're going to squeeze the bag to give a breath, 1 second. Squeeze the bag over 1 second just as you would in an adult patient. And of course, you will be using a pediatric BDM. So you're going to watch for the chest to rise. If the chest does not rise, we need to reposition the airway. And attempt again. 1 rescuer is 30 to 2. 2 rescuers, 15 to 2 ratio on compressions to breath. Foreign body airway obstruction. If a patient's airway is obstructed and they are actively coughing, we need to encourage them to cough. If we encourage them to cough, they can forcefully move the object out of their airway. Once the patient's airway is completely obstructed, it is time to perform abdominal thrust. Abdominal thrust, just as shown in the picture, your placement is going to be, you're going to put your hand into a fist, you're going to go just below the xiphoid process into the abdomen, you're going to press in and up. You're going to try to forcefully get that object out of their mouth. If the object cannot be freed and the patient becomes unresponsive, during abdominal thrust, place the patient on the floor and immediately begin CPR. And again, for an adult, 30 to 2. Abdominal thrust, we need to approach the patient. Are you choking? If yes, can you speak? If no, tell the victim you're going to help. The universal sign for choking is this. Even children know this. They automatically do this. It's like a natural reflex. I'm choking. You can't breathe. We need to give abdominal thrust, chest thrust for the pregnant or obese victim. We need to avoid compressions on the lower sternum. Repeat thrust until the object is expelled or the victim becomes unresponsive. At that point, we start CPR. Foreign body airway obstruction for an unresponsive adult. Activate the EMS system or send someone to activate it. Begin CPR without a pulse check. You're not going to check for a pulse. We know that there's an airway blockage. You're going to start immediately onto chest compression. After 30 compressions, open the victim's mouth wide and look for an object before giving breath. If you see an object, remove it with your fingers. If you do not see an object, give a breath. Important note here, we don't want to do a blind finger sweep. You could push the object even further back into their airway, which is not a good thing. If the breath does not go in, we need to re-tilt the head and give another breath. If the breaths still do not go in, continue with cycles of chest compressions and ventilations until the object is expelled. When you're doing the chest compressions, you're creating enough force to imitate a cough as the patient would be doing initially, coughing, trying to remove the object. Okay, after you relieve choking and see the chest rise when you give 2 initial breaths, we need to check for a pulse. An adult patient is going to be in his garage. If no pulse and no breathing or no normal breathing, only gasping, we need to start CPR and attach an AED. Okay, child infant choking. Foreign body airway obstruction in a child. We're going to approach the child. It's important that you approach a child on their level. Ask the child, are you choking? If yes, can you speak? If no, tell the child you're going to help. Give abdominal thrust using the proper hand position. We need to avoid the xiphoid process. Children are more fragile than adults. Their bones are still fusing together, and we don't want to damage the xiphoid process. Repeat thrust until the object is expelled or the victim becomes unresponsive. In an unresponsive child from body airway obstruction, if a second rescuer is available, have him or her activate the EMS system, call 911. We need to begin CPR. We do not check for a pulse, starting with compressions. After 30 compressions, open airway and look for an object. If you see an object, remove it. Again, no blind finger sweeps because you may push the obstruction object further into pharynx. Then try to give a breath. If it doesn't go in, re-tilt the head and try to give another breath. Okay, now your child has gone unresponsive. We're going to continue with cycles of chest compressions and ventilation until the object is expelled. After 2 minutes, if no one has already done so, we need to activate EMS by calling 911. If you do not see an object, keep doing CPR. After you relieve choking and see the chest rise after giving 2 initial breaths, we're going to check for a pulse. In a pediatric patient, we're checking for a pulse in the brachial artery. If no pulse and the patient is not breathing or not breathing normally, we need to start CPR. Infants, foreign body airway obstruction. We need to check for seriously breathing difficulty, ineffective cough, no strong cry. Confirmed signs of severe or complete airway obstruction. When you see an infant and they're not awake and they're not crying, that's not a good sign. A silent baby is not a good baby. We need to immediately give 5 back blows and 5 quick compressions. Same location on the chest compressions, just below the nipple line. Deliver chest compressions with the intention of creating enough of an artificial cough to dislodge the foreign body. You're going to repeat step 2 until the object is expelled or the victim becomes unconscious. So I have an infant here, and let me just give you a quick demonstration. You're going to turn the infant over in your hand, and you're going to administer 5 back blows. Okay? Then you turn the infant over, and you do chest thrust just below the nipple line. 5. Okay? Like it says, you're going to create enough of an artificial cough to kind of alleviate the foreign body. If your infant goes unconscious, if there is a second rescuer available, have him or her activate the EMS system, call 911. It's very important. Start CPR with chest compression without a pulse check. We know that there's already airways obstructed, they're not breathing, their heart's going to stop when they stop breathing. After 30 chest compressions, open the infant's airway and look for an object. If the object is visible, you can remove it. Again, do not do a blind finger sweep. Attempt to give a breath if it does not go in. We're going to reposition the head and continue CPR, starting with compressions and ventilations until the object is expelled. After 2 minutes of CPR, if no one has called, activate the emergency response system. After you relieve choking and see the chest rise when you get to initial breaths, check for a pulse, again in the brachial artery. If no pulse, no breathing, or no normal breathing, start CPR. Alright, some take-home points for adult CPR. After recognition of cardiac arrest, call for ALS help immediately. That's as simple as calling 911. After help has been called, begin CPR beginning with compressions. Compressions need to be hard and fast. Again, you're going 2 inches deep, at least 100 per minute. We want to minimize interruptions in compressions. There is no change in ratio for a 1 or 2 rescuer CPR for an adult. Hands-only CPR is an option. As I said earlier, AHA is moving more towards a hands-only approach to CPR. Take-home points for the infant and child CPR. After recognition of cardiac arrest, we need to perform 2 minutes of CPR, then activate the emergency response system. Compressions must also be hard and fast, at least at a rate of 100 per minute, a third of the depth of the chest. Minimize interruptions in compressions. 1 rescuer is 30 to 2. 2 rescuer CPR is 15 to 2. Now that covers your child and infants. Let me just bring up a point on your neonates. Birth to 28 days. Your ratio is 3 to 1. 3 compressions to 1 breath. Alright, does anybody have any questions? If not, we're going to move on into a team approach CPR demonstration.